Today, we're going to examine a new clinical practice guideline designed to standardize surgical clearance. The objective here is really twofold. First, it's about building a robust, defensible framework for our preoperative assessments. And second, it's about fundamentally changing how we, as different departments, communicate a patient's readiness for surgery. So, what's the core problem we're addressing? It's the ambiguity we all encounter daily. It stems from these informal, narrative-based communications between anesthesiology, surgery, and theater scheduling. This new framework is designed to replace that ambiguity with a shared, unambiguous language, a structured, categorical system that ensures every single stakeholder has the same clear understanding of a patient's status. All right, here's our agenda. We'll begin by framing the problem of ambiguity. Then, we'll introduce the four-category framework that serves as the backbone of this solution. From there, we'll walk through the specific pathways for cleared, pending, and postponed cases, delve into the high-risk MDT protocol, and finally, discuss how this establishes a new, and I think you'll agree, more defensible standard of care. Let's start with the foundation of the entire system, the four-category framework. You can think of this as the master matrix for patient readiness. It's what dictates every clinical and administrative action that follows. This master matrix is our single source of truth. Each of the four categories has a very clear theater status and a primary action. Category 1 is simple, book. These are our cleared patients. Category 2 places a case on hold pending a complete evaluation. Category 3 is a postpone for necessary medical optimization. And finally, Category 4 is a hard stop, do not book, which automatically triggers a high-risk multidisciplinary team review. Now, the integrity of this protocol is built on four non-negotiable principles. 1. Any testing requires clear clinical justification. 2. Risk calculators are there to inform our clinical judgment. They do not replace it. 3. Our documentation is the definitive medical legal record. And 4. Shared decision-making is our absolute standard for consent. It's also important to note the scope here is strictly for adult, elective, non-cardiac surgery. To put this into practice, we use a clinical input dashboard. This integrates several validated tools like the RCRI, ACS-NSQIP, and the clinical frailty scale. But I want to be absolutely clear. These scores help build a risk profile. They are inputs for our clinical judgment. They are not the determinants of it. For example, a clinical frailty score of 6 or higher should immediately make you consider a Category 4 MDT evaluation. Okay, let's now review the specific pathways. We'll start with what we can call the green lights, the direct clearance categories. And then we'll look at the critical safety gate of the administrative hold state. Category 1, our cleared status, is actually stratified into 3 distinct pathways, and this is based on the anticipated level of postoperative physiological stress. 1A is for your standard day case surgery in stable patients. 1B is for extended recovery, so up to 23 hours, for patients who might have moderate OSA or more complex pain management needs. And finally, 1C requires inpatient admission for major procedures that generate high physiological stress and demand inpatient-level care. Category 2 initiates an active administrative hold. This is triggered by any incomplete evaluation. And I really want to stress that a hold is not a passive waiting game. It mandates a 3-part action plan. First, you document exactly what information or test is needed. Second, you assign a named person or role to be responsible for it. And third, you set a mandatory review date. And let's just underscore this point because it's so important. An entry of results pending without that clear accountability and a timeline is quite frankly a medical, legal, and operational failure. It creates a dangerous accountability gap that leads to delays and potentially patient safety incidents. As long as the case is in Category 2, no operative date can be confirmed. Period. Right. Next, we need to address the categories that require definitive medical intervention and result in the formal postponement of elective surgery. I want you to think of these as active patient safety interventions. So a Category 3 designation means the patient is not cleared. We apply this when an active or suboptimally controlled medical condition makes the risk of elective surgery unacceptable at that moment. It's absolutely imperative that we communicate this to everyone involved as a safety-focused postponement, not a refusal of care. The goal here is to mitigate risk by achieving specific, actionable optimization targets. And here you can see some specific clinical triggers for Category 3 status, anything from decompensated heart failure to an HbA1c over 10%. But crucially, for every single trigger, we have a corresponding, clearly defined reclearance target. So this isn't just a no, it's a not yet, and here is the precise clinical goal we need you to reach. Next, we move to our highest risk tier, Category 4. This category mandates a formal MDT protocol for our most clinically complex patients. Category 4 acts as a mandatory multidisciplinary bottleneck. It's triggered when that harm-benefit balance simply cannot be determined with confidence by a single clinician. Key triggers include things like severe frailty, an estimated 30-day mortality risk over 10%, significant multisystem organ disease, or a major discrepancy in the patient's goals of care. This is an absolute do not book status until the MDT has formally convened and rendered a decision. The rationale for this MDT is compelling. The evidence shows that these discussions modify the management plan in 81% of high-risk cases. They also lead to fewer extended hospital stays. This approach aligns with all major international guidelines, and it fundamentally shifts our focus from a simple fit or not fit decision to a truly holistic determination of the best care pathway for that individual patient. The MDT process itself is rigorously governed. A quorum is mandatory. It must consist of the lead anesthesiologist, the primary surgeon, and at least one relevant medical specialist. And crucially, the quality of the decision is directly proportional to the quality of the information presented. That's why a standardized case summary with all relevant risk scores and investigations has to be submitted 48 hours before the meeting. The meeting itself follows a very strict 5-step framework. It kicks off with a structured case presentation, followed by focused input from each specialist. The team then explicitly frames the risks, and that includes discussing the natural history of the disease without surgery. The 4th step, integrating the patient's stated goals of care, is a non-negotiable gate before you can proceed to the final MDT decision and action plan. The medical legal dimension here is paramount. The formal MDT decision record, which must be completed within 24 hours, provides a documentation shield because it demonstrates institutional due diligence. It has to record not just what was decided, but why. The framework also has clear principles for documenting any dissent, which shows intellectual rigor, and for ensuring the patient's consent is fully informed by the MDT's conclusions. So, to conclude, let's pull all of this together and look at the system-wide benefits, which I believe culminate in what is truly a new, more defensible standard of care. One of the key safety benefits here is the activation of what's known as the Hawthorne effect. When a patient's high-risk Category 4 status is actively broadcast to the intraoperative team, to PACU, to the ICU, and to the ward teams, it measurably increases clinical vigilance throughout the entire perioperative journey. It's not enough to just hold the meeting. That categorization has to be communicated system-wide to be effective. And this flowchart really synthesizes the entire system. You can trace the complete patient journey, from the initial assessment, branching into one of those 4 triage pathways, and leading ultimately to a final, documented, and defensible patient safety outcome. It's a logical, comprehensive protocol that is designed to eliminate ambiguity and enhance safety at every single step. I'll leave you with this final thought. How can we take the core principles we've just discussed, structured communication, tiered risk assessment, and clear accountability, and adapt them to improve other complex clinical